Next thing we're going to talk about is lumbar procedures. Lumbar procedures are generally a lumbar transfemoral, lumbar facet joint nerve block, a lumbar facet joint nerve ablation, an interlaminar epidural in the lumbar spine. Then in the sacral, we'll have a transfemoral in the sacral. We can do ablations to the sacral nerves, and then we can also do a caudal epidural. Okay. We'll start with the transfemoral. Transfemoral just literally means through the foramen. The foramen is the hole on the side of the spine where the nerve comes out. And that's what we call it, the foramen. Foramen literally means window, if I didn't say that. So what's going in and out of the foramen? Well, we've got the nerve, the segmental nerve, okay, the spinal nerve. But often we have some veins going in and out. Occasionally we'll have an artery. There's one artery in particular that we're trying to avoid. It's called the artery of Adamkiewicz, and it feeds the spinal cord. If we are in that artery and we inject medicine that may cause a spasm or actually clot that artery, like a particulate steroid, we paralyze the patient. Okay, so we're always trying to avoid that artery, and luckily it's fairly easy to avoid. It usually occurs in the thoracic spine. It usually occurs on the left, but it can be as high as the cervical spine. Sometimes it's even as low as the sacral.
So all different levels.
It can be on the right, it can be on the left, it can be everywhere, it can be anywhere.
Okay.
But in about 70-80% of patients, it's going to be somewhere in the mid to low thoracic spine or very high lumbar spine. But so we try to avoid that artery. We try to avoid the nerve. We don't want to inject the nerve or the arteries or the veins. So most of these things come from a projection of like this. And this is, again, the Scotty dog view. You can see the nerve will come right underneath the pedicle, okay? And what's happening is you can see in this projection right over here, the pedicle is this connector. This thing right here is called the pedicle. It is the bone which connects the facet joint and the lamina to the vertebral body. It projects as a ring or a hole. And so when we look down the actual oblique view, we're going to be looking right down the actual axis of the pedicle. Now in this, if you just turn this, you can see this would be the same projection coming looking at the camera or the screen or the x-ray, where you could see the disc right here, the disc being this inner space here, this being the end or the end plate or the vertebra, this being the wall of the vertebral body, this is the inferior end plate, this would be the transverse process right here. Then we have the pedicle, which is the red circle. Then we have the superior articular facet, or SAP. Okay, this would be the inferior. And then this would be the pars, we'll call the pars interarticularis right here. And that's what is fractured that we saw earlier. And so this star is where you don't go. That star represents probably dead center path of the nerve. If we're to place the needle, we'd probably get this projection, then we'd numb up the skin right here or here. Then we'd walk slowly over and we'd put the needle right under the pedicle, and the nerve would be coming right here, so we'd be lateral to the nerve and hopefully lateral to the arteries. There is an argument that almost all arterial and vascular, as well as the nerve bundle, come in the superior part of the foramen. This is the whole foramen. And so there's an argument, and a very rational one, that in order to avoid all of this neurovascular bundle, what we do is just come in and then walk off here and go over the disc, or what we call retrodiscal approach, or a discography approach, or the other way, this is called Cambin's triangle, where we'd start here and then put the needle right here. Arguably, it's probably a little bit safer. A lot of doctors still come just lateral to the actual pedicle itself. But nevertheless, the idea is place the patient in the prone position like so, get them comfortable, and then what you're going to kind of do to get this angle is, let's say this is, we know it's not L5 because we can see an another vertebral body here. Okay, this is an L5. So it probably is L4, it may be L3, we can't really see the sacrum. The first part of imaging in the lumbar spine, if you're going to do a transfemoral, you got to know what level you're going to do. So if you're going to be doing any level, to know where you are, you generally count from the sacrum. Okay? It's not 100% accurate, but it's almost. And the reason I say that is really the only way to know to count the vertebrae is you have to start at the skull and work down. Because sometimes people have 6 vertebrae in the lumbar spine. not the normal 5. That said, you want to show the doctor the sacrum. Once he sees the sacrum, he or she can count up, okay, and then know that this would be L5, L4, L3, L2, L1, T12, etc. Let's say we're going to do an L5. What we do is we come down here, we show the doctor the sacrum, the tip of the sacrum, and also you're going to see the L5 vertebral body. You want the C-arm to be oriented in the exact same, so the disc would be on plane, right, like that. So, and if you look at the skin of the tush, right, it's going to be parallel to the skin of the tush. And you make it the image intensity parallel to that, and then what you would do is you'd simply probably go into the oblique position to show that projection of the Scotty dog view. It's not going to be good with this. It's not at all. But what we can see is we can see on the screen, we can see there's the disc in plane, right? This disc is almost in plane. This disc is a little out of plane. Here's the wing of the ilium. The sacrum's going to be here. So if we were to do this Camden's triangle retrodisclector, we come right down there. We can't see the pedicle or the Scotty dog here, but we go right there. But that's the concept. Some doctors, and I've done it this way many times, you just start AP. But most doctors like an oblique view. And of course, you go oblique if we're going to do a right-sided transfemoral, you're going to oblique to the right. If you do a left-sided transfemoral, you oblique to the left. How much is enough? Once you get that Scotty dog view, you generally have enough, and the doctor can work with it. Now, going back to this picture, let's say you haven't given the doctor enough, okay? Let's say you don't have enough oblique. What will happen is, as you move the C-arm more to the AP, the projection will be more looking down this angle. And the problem is this is an oblique projection, but what will happen is that the opening will project over the nerve, and it will look like you have enough room when you don't, and you could place the needle into the nerve. So that's the idea. If in doubt, go more oblique. You can always go less oblique easier. Okay. One thing about knowing where the projection is, one way to know if you're oblique or if you're AP is looking at the spinous process itself. Okay, and this is the spinous process, which is this part of the anatomy, this thing that you can reach back there and press on and feel in a thin person. This thing, when it's looking right at the spine, should project just vertically. You just see like a fin. It'd be like looking at the fin top down on the dolphin. Okay, and this is the fin of the dolphin. And you can imagine that if you're tilted a little way, it's just like someone's nose. You'll see it tilted and you see more of the nose. If you see more of the nose looking one way, then you know you're not AP. Like this, you see the nose looking right at you, and it's AP. And that's how you know your projection. Because sometimes what will happen is these vertebral bodies won't be all the same. They'll have a little rotation. One may be to the left and the other one's to the right. And so to know whether you're truly AP, you got to look at the spinous process of that particular vertebral body. And so, like in spinal cord stimulation, we may find that there's a lot of rotation, especially here in Florida. There's a lot of twisty ladies and men down here. We've got a lot of rotation in their spine. And you got to simply, as you're going on up, the fluoroscopist has got to be moving the C-arm and adjusting as they go, and always knowing where that nose is looking. If you look at the nose, you will know. Here you can see a perfectly AP view. The reason is you can see just as much. You see this spinous process here? See the white right there on the either side? It's the same amount of white, almost exactly on either side. That's when you know you're looking right at the face. The nose is perfectly looking at you. Same thing here, same thing here, same thing here, same thing here. We'll look at a few where it's not like it. This is a great picture. And what's great about it is that you can see the sacrum, you can see the ilium, you can see the SI joint. So if the doctor said, I want to do a L4, if you showed him this first, he would know there's the L4. Once you guys get a good relationship, say sometimes I'll walk in with Louisa or Lydia or Michelle, and I trust them. After a while, I know, I want to do L4. They've counted up, and they'll always, if it's not obvious, they'll want me to know that they know. So what they'll do is they'll focus in on the L4, but then they'll leave it not magged so I can see everything. So the first projection will be focused on L4 in the right position, but they'll allow me to see with that first picture the sacrum, so I know that they know. If it's totally obvious, then I will allow them, they may just project the first one to be magnified and perfect, and we just go from there. But as long as you can see the sacrum, you know where you are, because you know where L5 is, you know where L5 is, you know where L4, you know where L3 and L2. So sometimes, let's say we have a high one, like an L1 or an L2 or an L3, you're in the middle, it's magnified. You may not see the sacrum. The doctor, you know, unless you guys have a perfect working relationship, or you know, you're going to want to show the doctor her or his sacrum so that they know we're in the right spot. If we do the epidural in the wrong spot, you can't trust the results. You may say, man, that epidural didn't work, even though you were in the wrong spot, thinking you were in the right spot, and you don't return to that spot. And the patient doesn't get relief. Okay, so I brought up an image. Let's have a look at this image there. Now, TG, why don't you just come here and look at this with me. Which one of these to you, and I'll give you the pointer, does not look like it's AP? Can you show me?
You want me to say what it is?
Yeah, sure. Tell me.
So I'm thinking L3
Yes.
and L4 because they are actually going the opposite way. They're not straight. So they're more to
exactly
the right.
And so what are you looking at on the spinous process that shows you that it is AP? Like you're looking at, you see some lines, white lines, correct?
You see both of the lines on L2 you see both lines here,
Yep.
and on L3 and 4 you only see them on one side.
Correct.
Right here.
So what would you do? How would you move the C-arm to make it so that those two specific segments were more AP? Just like looking here on the, how would you, let's say this is the beam. Would you move it more like this or more like that?
More to the right.
Yep, that's exactly right. So you'd move it more like that, and then all of a sudden you'd see the sclerotic line on this side and on this side better, showing you that you are indeed AP. That's exactly right. Good job. What we're talking about is an interlaminar epidural. An interlaminar epidural is different than a transforaminal. It's different in that when you have the spine, and what you can imagine is a spinal column, and dura and the sac is like literally like a says that we get medicine in front as well as in back of the sac. Okay, that's the idea. And that's why it works a little better than an interlaminar for a pinched nerve in the side. When we have a pinched nerve, say this is a herniated disc, it's always going to be pressing the nerve root in front. It's never coming from the back pressing in. So the closer we are to the pathology, the better. But sometimes, and especially it seems with spinal stenosis, an interlaminar epidural works even better than a transforaminal. So the idea is that instead of coming from the side, we're going to come literally from top down. Now, so it means that the patient's in essentially the same position, but our projection is going to be AP. And again, if we put a pillow under there to open up and bend the spine, you'll have even more space to get into interlaminar. What we generally do is numb the skin, put the needle down to the bone, and then walk off into the ligament inflated, and then use what we call loss of resistance technique as we pass it through. But from a fluoroscopic idea, the concept is that you want to be basically just on the exact plane as the disc, okay? And if that disc is sharp, what we call the end plates of the vertebral bodies, this is an end plate here, this is an end plate here, on top and on bottom, just before you get to the disc. If those are crisp on that segment that you want to do, then you're going to be in good stead. So let's say you wanted to do a, this is 5, 4, 3, 2, in L2-3, interlaminar epidural, you'd come and you'd have the spinous process of L3, spinous process of L2, they'd be nice and sharp, right, because they're looking right at you. And you'd want the disc right here, so the inferior end plate of L2, the superior end plate of L3 as crisp as possible. Let's just take a floor shot. This spine will do that. So try and take someone in. So you see what Michelle's doing here. She's moving that seam. First she's going to go up and check to see if this makes it more clear. It doesn't. So now she notices that it doesn't, so she's going to try more caudocephalad angulation. It's better, right? Now you can see space between the discs right here. And maybe even a little better. Let's try it a little more caudocephalad. That's even better. See, now this disc is even wider and thicker. Maybe even try going a little extra, a little too much, and just see what happens. It may make it better, it may not. Nope, it didn't. So we're trying to find that perfect spot where the disc is crisp, okay? And you can see it on this projection here.